Good morning, everyone. For those of you who do not know me, I'm Ken Yonda. I am the founder and managing principal of a new consulting firm, Wild Blue Health Solutions, helping providers and payers navigate the complex world of value-based care and increasing coverage in the state of Texas. We're very excited today to have our first discussion with folks from the great state of Pennsylvania. And so we're very fortunate today to have Jessica Altman, who is the Insurance Department Commissioner, and Zach Sherman, who is the Executive Director of the Pennsylvania Insurance Exchange, the brand new insurance exchange, talk to us about how they have used a 1332 waiver to create a state-based exchange in Pennsylvania, as well as reinsurance to lower the cost of insurance and hopefully expand coverage to more people in Pennsylvania. So we're very glad to have both of you here today. As we get started, I want to share my screen for just a second to show our audience. When I find it here, let's see. I'm going to share. Hopefully you guys all can see this. This is the 50 states, and you'll see the light blue area are the states that have a federally facilitated marketplace like we do here in Texas, healthcare.gov. You see the very dark blue or black states like New Mexico and Arkansas, which have a state-based marketplace but run on the federal platform. And then sort of the navy blue states here, California, Nevada, Minnesota, and now Pennsylvania, which are running their own state-based marketplace. And so we want to hear a little bit today from Jessica and Zach about the decision to move from a federally facilitated marketplace to a state-based exchange, and how's it going. So I will turn it over to Jessica to give us a little bit of the history first, and then we'll get into it. If you do have questions as we go along, do put questions into the question and answer box on your Zoom screen, and we will answer those questions a little bit later after Jessica and Zach have a little time to make a bit of a presentation. So take it away, Jessica.
Thank you so much, Ken. Hello, everyone. Thank you so much for having us. It's really fun for us to talk about a project that has been near and dear to my heart, certainly is Zach's living and breathing every day, and to hear that another state has some interest in what we've been doing is really, really exciting for us. So a privilege to be here talking to you. Zach came on once the legislation started, so I'm really going to take you through how we got to the part where I did made one of the best decisions I made in hiring Zach, but up until that point, how we secured the legislation in Pennsylvania to do both the state-based exchange and the reinsurance program. For those of you that spend time in politics or state government, it will not surprise you to know that this was not the first time we talked about either of those things. There is a tendency to kind of repeat conversations in state government, and this was no different. We in Pennsylvania had, I think like many states, talked about a state-based exchange in 2010 through 14, when all states were having that discussion. Different administration, I wasn't there at the time. Ultimately, we decided not to do that, both for political but also for operational feasibility reasons here in the Commonwealth. And so we, from the beginning of the ACA, were on the FFM. We also then talked about moving to a state-based exchange, or at least a state-based exchange on the federal platform, when King v. Burwell was circulating and there was the potential of losing our tax credits. But of course that didn't happen, and we kind of lost the political steam to do that at the time. So, we had always known, we had seen the evidence, and if you're not familiar, that state-based exchanges have better outcomes, they have better enrollment, lower uninsured rates, more affordability of the products because of competitive dynamics. And there was a lot that we knew we could do with a state-based exchange. We just weren't sure how we could get there, given the cost and the operations and the politics, excuse me. Reinsurance, of course, I think everyone knows everyone wants to do reinsurance. It's a great way to stabilize your market. It's one way you can measurably actually drive down premium costs. Many states have done it. I always say, we have a very stable market in Pennsylvania in recent years, but I'm often caught saying stability and affordability are not the same thing. And particularly for the higher income bracket, we had some work to do on premiums. And so reinsurance is, I think, the natural place for states to look. But like many states, we were really stuck on how we would fund the state portion of the reinsurance program. The two ways other states have commonly done it are either through an assessment on industry, which I'm sure in this audience is no secret that our industry would not love to see. It was very important to us that we have the insurance industry as well as other stakeholders on board with what we wanted to do, both functionally, but also to make sure that we had the right support heading into legislative discussions. The second is just using state general fund dollars. That was not going to happen in Pennsylvania. We do not have a handy budget surplus like some of our colleagues, and we have had some pretty tough budget discussions in recent years, even before sorry, I'm seeing that I'm supposed to be showing slides, and that's true, although I haven't gotten to the point where I need to talk to any of them yet. So yes, Ken, I will share slides. Thank you for that. And so we kind of had these two things that we wanted to do, but we didn't know how we could really accomplish either of them. And then something kind of came to us, and that was that how the technology that backs exchanges had so fundamentally changed in recent years. We saw Nevada's transition to a state exchange, and that they could really not have to build their own exchange, but instead by contract procure technology of an exchange that had already been built, was already being used, and deploy that. And that really changed the game, not only on, of course, the operational feasibility, but also on the cost. And in fact, let me move to share some of these right now. What we started to realize is that with the cost that we were paying to healthcare, there we go, to healthcare.gov to run our exchange for us and to do it not in the way that we thought was ideal, that we could take that same user fee, not raise it, so no additional cost. We could run our own exchange and do it the way that we wanted to do it. And we could do that with enough money left over to also fund our reinsurance program at a moderate level, about a 5 to 10% savings estimate from that. And so we had kind of, first of all, I'll say that construct not going to work in every state because Zach can get into this, but there are some economies of scale, but I'm pretty sure it would work in a state like Texas, which is even, of course, larger than Pennsylvania. But we really had to delve into the numbers, and we did see that we could make that work. And so, as we put this together, you can see on the slide here, a lot of the key things we were able to highlight with this construct. First of all, a lot of flexibility with our own exchange, better customer service, reacting to changes and serving Pennsylvanians in the way that's best for them, local control of the program, ability to better coordinate with other state programs, lower cost, increased premium savings from the reinsurance program, foster a more competitive marketplace, and better coordination there, oversight and management of the churn population. All of these things were a part of the proposition that we were able to put together. And we first started, then we went to our stakeholders and we said, we have this idea, we've run a lot of numbers, we really think it's going to work. And we were able to put together something very rare in politics, which was a coalition where every relevant stakeholder was supportive of the initiative and no one was opposing what we were doing. And so I think that plus, of course, no, we weren't asking the legislature for any money. And again, for those of you that work in state houses, or have colleagues that do, if you can come just off the bat with something that says no money and everyone thinks this is great and no one thinks it's bad, you're already ahead of the game relative to 99% of other legislative proposals, probably 99.999% of other legislative proposals that come through. So that was a pretty exciting thing to put together. Our insurers were on board, our agents and brokers were on board, the consumer groups and advocates were on board, the business community was on board. The medical community, the hospital association and the medical association were on board. And so we had a really exciting coalition. And that really is what brought us to taking this to our legislature. Now, Pennsylvania, if you're not familiar, I serve Governor Tom Wolf, who is a Democrat, but I work very closely with our legislative leaders in both chambers who are majority Republicans, and the leaders are Republicans. And so we had to do this in a way that could appeal to both parties. And we were, I think, through the arguments that I've already gone through, able to secure support. We started with a very convincing sort of a key player at the time, the majority leader of our House, now the Speaker of our House. He became our lead sponsor alongside the minority leader of the House. And so we had some really great leadership to begin with. And I'll just skip to, at the end of the day, on final vote, this legislation passed unanimously in bipartisan fashion in both chambers of the Pennsylvania legislature, and was signed with fanfare by the governor with members of the leadership of both parties and myself alongside him. So it was a very exciting. People have told me numerous times it was the fastest they have ever seen legislation move in Pennsylvania. We briefed the legislature for the first time in February of 2019. We had legislation introduced end of March or early April, and the governor signed the bill on July 4th. So that is a whirlwind. And a couple months later, we immediately, Zach will get into more of this, started on our contract, brought Zach on board, and started getting to work to get where we are today, which is in the midst of what is already a very successful open enrollment for Penny. So that is, Penny is is our state-based exchange. So that's how we got here. I'm thrilled to answer any questions or talk more about it.
Why don't we go to Zach now for a little bit of more details about the exchange itself and how you stood it up, and then we'll save questions for after Zach talks for a few minutes. But again, those of you in the audience, if you will put questions into the question and answer area, we'll get to those a little bit later. But why don't we go to Zach for now?
Great. Thank you, Ken. And thanks for the opportunity to be here to talk a little bit about this effort. So as the commissioner mentioned, I came on board after the law passed and was enacted, and was largely charged with standing up the state-based marketplace, bringing it along, getting us to a place where we could take it live operationally on November 1st of this year, 18 days ago. So when I showed up about a year ago, a little over a year ago, we had basically three primary focuses. One was building the infrastructure for a state-based marketplace, and that includes hiring a vendor to build and launch the eligibility and enrollment platform, the key technology platform, as well as a customer service vendor to serve Pennsylvanians with questions about the application process, technical assistance, all sorts of things during open enrollment as well as during the year. Our focus there was to structure a procurement in a way that would cost us no money in the first year. And that's very key. As the commissioner mentioned, this initiative was put forward funding two programs and requesting zero state dollars to pay for it. So we had to figure out a way to bring on a vendor to build the thing during the first year, during 2020, and do it at no cost during that year. The other focus was bringing on vendors that had done this before. We all lived through some version of the experience of healthcare.gov, where there were stumbles and falls out the gate, and we very much wanted to bring on vendors that could support the transition, that had done a transition, that had experience doing customer service and technology in other state-based exchange states. And so those were the no cost in the first year and experience in other states were key baseline requirements of our procurement. And so that's the way it was structured. The way in which we were able to make it no cost in the first year is we structured the payment for implementation costs as something that they would bill us, but get paid for over the life cycle of a contract. And so they did the work this year. They are charging us for the funds, but it's being amortized over the next 6 years. So that's how we figured out a way to get the work done, get the work charged, but not pay for it in the first year. And no, Ken, I don't have any slides. So I'm just giving a base overview of the work. So that procurement landed us in a good place. We were able to. There was healthy competition in the vendor space, and ultimately we landed with Get Insured to support both the technology platform and the customer service. And they have performed well in other states, including California, Idaho, Nevada, and a couple other states. So that was a key first thing that we worked on. We ran that procurement pretty quickly and had a vendor on board, starting the implementation process basically in January of this year. The other focus was building out our identity, building out an organization. We needed to make sure we had a name, a market strategy, an ability to understand where the customers, where existing customers across the Commonwealth are, as well as where the remaining uninsured are, because at our core, we're interested in expanding access to coverage across the Commonwealth. And those that are uninsured are a key target demographic for us. And then lastly, and really importantly, the focus was building on the great success of the bipartisan collaborative effort, was continuing to work with and engage with stakeholders on the implementation. A key stakeholder to keep involved and to bring along, and who had as much to do in terms of transitioning was the insurer community. All of their systems, all of their enrollment systems had to be transitioned from healthcare.gov over to this new platform. And there's a lot of work that goes into that. So working very closely with the insurers throughout this year was very key in getting to a place where we transitioned all of the enrollment over, ran the renewal process, and got everybody into the new program, into the same plans that they were enrolled in, if that's what they wanted, and up and running for open enrollment. We spent a lot of time with insurers throughout the year working on the transition. We worked very closely and actively with the insurance broker community on making sure that we learned about what worked with healthcare.gov, what could be improved. We worked with them to ensure that their existing books of business were transitioned over, so they didn't have to start over from scratch. We worked very closely with the existing Navigator network in the interest of continuing that work, but also bolstering it and building it up to ensure that Pennsylvanians across the Commonwealth have access to in-person assistance, unbiased navigation support. And all of that was really key in leading up to transitioning, turning the corner from all of the background work of just building the infrastructure, launching, implementing the thing, turning the corner around September, where we introduced the marketplace and said, we're making this transition. Penny is here. Penny is the new state-based marketplace. Please come in. Please be aware. Please come in. Come November 1st, open enrollment is coming. And so, you know, that's the work of the past year. We got to November 1st, the first big initiative that had to go well was the renewal process. We ran renewals right before the start of open enrollment, and I'm happy to report that that went very smoothly. That went very well, with few exceptions. People who were supposed to renew were renewed. And then on November 1st, we opened for business. We started, customers started coming in on day one. They started paying their bills on day one. We started sending the transactions, the enrollments over to the insurers. Brokers, assisters were assisting people on day one, and it's been steady and constant enrollment, both active renewals and new enrollments. It's been steady and constant since day one. So I'm happy to report that the bipartisan effort to make this thing happen is being realized, and that the transition has been effectuated, and we're off and running. And you know, in case you're wondering, we did not ask for any state dollars to make this happen. That was the plan, and we have made good on that plan as well. So
before Ken opens for questions, I'm going to put in the background this slide that kind of shows how I'm not going to walk through it, but for the nerds in the audience, this kind of walks through how the dollars flow between the collection of the user fee, the exchange funding for its own operations, and then the reinsurance program that's housed within the insurance department and not the exchange, which is a separate entity. And I just think it's helpful to have in the background, and I wanted to pull that up. I'll also just add to what Zach said. A critical part of our planning and our messaging was that for the first year, if we were really going to pass this thing in July and stand it up a little over a year later, we had to put operations first. We had to focus on getting a system that would work and enroll people and not crash, and a call center that would answer phone calls come November 1. And if we got to the point where we were comfortable, we were going to do that, then we could talk about bells and whistles and extras and things. I think that was a real lesson learned from some of the early exchanges. And so for me, you know, before I had Zach, when it was myself and my then chief of staff, you know, kind of running this off our desks, it was get the contract out the door and move that thing as quickly as you can, and find the best team you can and get them on board as quickly as you can. And that was really the focus. And we kind of continued to stress that to set the right expectations for our stakeholders. And obviously we were able to do it. New Jersey was able to do it. Some of the other states that are moving are giving themselves an extra year of runway than we did. But it is possible, but you need to get buy-in from, you know, all your other partners within the state, the HR team, the IT team, the communications team, your Medicaid agency, which we were able to do, ruffled a few feathers along the way. I'm not going to be shy about that. The contracting teams, right? But we were able to do it. And I think when you bring all those people on board, you can move things a whole lot faster in government than you might think. And I'll tell you, as much as our legislation timeline broke some records, I think our contract timeline was even more so. So just an important thing to highlight there.
Great. I have a couple of questions, and we're starting to get some in the Q&A, and so I encourage people to continue to put their questions out there. But I'm still a little bit confused about how you were able to do this without any money, right? Zach get a paycheck, right, before there's any members, before there's any fees flowing. So there's talk a little bit about how that part worked.
Yeah, I'll take that. So there were really four pieces of that, two big ones and two smaller ones. The two big ones, one Zach already tackled, which is our big contract. We have a single contract for the entire IT infrastructure and the call center. We procured to not start paying until we were collecting the full state-based exchange 3% user fee on January 1st of 2021. And if you're doing the math, that's correct. We haven't paid $1 on that contract yet, and we have a live exchange. That's I think it's a little of a novel idea. It's definitely a hard thing for vendors to deal with, but I also think the vendors in this space have a pragmatic realization that if they want more states to be able to do this, they're going to have to be willing to get creative with us because of the way the financing streams work and the timelines work. So that was huge. That's our largest cost. The second is we transitioned immediately to a state-based exchange on the federal platform, which requires some moderate steps to be taken by the state, mostly around outreach and marketing. In Pennsylvania, we were actually already doing some of that ourselves, so that was easier for us, but other states that weren't were able to kind of turn that on a dime. But for us, we already had funding allocated to that, and so that wasn't an ask for us. But for your insurance department and whoever is working on this within their budget, it wasn't a lot of dollars that frankly we spent that year, certainly relevant relative to what Zach's marketing budget is today. And healthcare.gov still does marketing when you're an SBEFP. But more importantly, when you're an SBEFP, the federal government only collects 2.5% of premium for the user fee, not the 3% they collect for a full FFM. And what that allowed us to do is say, all right, insurers, we're going to just keep charging 3%, but that 0.5% is going to come to the state, and that's going to fund the startup cost. So that's what funds Zach's salary, as Ken put it, and his team's salary and their computers in the first year, and also the marketing budget for this OEP that we're currently in. There's also Medicaid match dollars at play there, which we're happy to get into if that's helpful, but you can receive federal dollars for exchange expenditures without needing your Medicaid program to spend any money. It's matching the state exchange expenditures. The two small ones were a Band-Aid loan from the insurance department to Penny that got us from when we passed the legislation to when the SBEFP user fee started coming in last January. That loan has already been fully repaid. It wasn't a problem to do that, but it was sort of more of a cash flow issue than an ultimate budget issue. And then finally, the thing that you kind of had left that an SBEFP is charged with doing that we didn't have an existing funding stream for is the Navigator program. And we were able to secure grant funding that funded that program for the first year. And so that was our strategy. But, I would stress that if you can figure out the contract piece and you can figure out the SBEFP transition, everything else is really around the edges on the dollars. Those are the two big pieces that really take money out of the equation in large portion.
And then let me ask one more, and then we'll go to some that we got a couple of really good questions in the question and answer box. But can you talk just a little bit about the legal structure of the exchange, right? I mean, it's not part of the insurance department, but it's its own separate entity. It has its own board of directors. And can you just talk about that a little bit?
Yeah. Zach, you want to take that one or you want me to?
I'm happy to. Penny, the marketplace, the exchange, is a quasi-public state agency. It's called a state-affiliated entity in Pennsylvania. It reports to and is governed by a board of directors that is the membership of which is statutorily set in our enabling law. The composition of the board is made up of 3 cabinet members, the chair being the insurance commissioner. So Commissioner Altman is the big boss. And I think that when you get to write the legislation about how it's governed, you get to also assign who's in charge. So there's some wisdom there. But the insurance commissioner, the secretary of the Department of Human Services, and the secretary of the Department of Health are the 3 cabinet officials. Then the governor has 4 appointments, 2 of which need to be from the insurance industry, 2 of which need to be consumer advocates or navigator type representatives. And then the last 4 board members are 1 each for each caucus in the legislature. So the Speaker of the House has 1, the Minority Leader in the House has another. That's rounding out the 11. The way it worked out is 4 of our 7 medical insurers are actually on the board of directors. And in the drafting of the legislation, I think it was anticipated and expected and known that there would be a little bit of, that there was going to be value in having members of the various stakeholder communities involved in the governance of the board, the governance of the exchange. And I will say, I came to Pennsylvania from Rhode Island, where I was the director of the exchange there. And when I was looking at the board composition in the legislation, I was a little nervous about so many insurers being on the board. But I just have to say it was, it's been really great. It's been really collaborative. The vested interest and the expertise that the insurance communities, that the navigators, that all of the members of the board who were so knowledgeable and also directly vested in the success of this thing has been a real, it's been a real asset to this effort, and it's really allowed us to move quickly and collaboratively in this implementation in this year.
Well, great. We're going to turn to the Q&A box and again, encourage people to continue to pop your questions in there first. The first one is, how did you pay for the reinsurance with no additional dollars? What's the impact on this year's premiums?
Yeah, that's a great question. So I'll start there and then Zach can add anything he wants. So as I said, when we look at what we are paying in expenses to run our own exchange, it doesn't add up to the 3% of premium, the revenue we get from the user fee. And it's that delta that really gets us the remainder of the funding for the reinsurance program. So while this fluctuates over time, just to give you some math behind that, before we took over, based on premium and enrollment on healthcare.gov, we were projecting somewhere between 80 and 90 million in annual user fee on the 3% level. And we were very committed to, staying at the same user fee level as the exchange. We just to then put another number, what we are projecting for 2021, we just did this yesterday on a board meeting, for our budget after the Medicaid match dollars, we're going to be spending about $31 million of that user fee for 2021 on operations for Penny. And so you can kind of do that math. That gives us a really nice delta, and that's how we are funding the state portion of the reinsurance program this year. It's about just over 5% that premiums are lower. It was the difference between premiums going up and premiums going down. So we have a statewide average decrease this year, which is very exciting. And of course, in the long term, once we cover the amortization of the startup costs, I think the outlook there gets even more positive in the long term as well.
One of the questions I always worry about because there's been some discussion here in Texas about 1332 waivers and reinsurance, and trying to explain both to the legislature as well as other stakeholders that the reinsurance tends to benefit the people who have no subsidies the most, and because people who are highly subsidized, the lowering the actual premium doesn't help very much. Were you able to actually explain that to folks in terms of who benefits from the reinsurance?
We did, yeah. We were very transparent about that, and I think it really goes back to the question of who are we really trying to help. And frankly, yes, I'm a believer that we need to do more to help the people that are receiving subsidies, but even more so, I think the 400% FPL cliff is really problematic, and people, who are trying to pay full price are really hit hard by the lack of subsidy. And so our goal was to make health insurance more affordable to that population. And we did definitely talk about that through the legislative process.
So we have another really interesting question and for Texas, and I really appreciate putting you guys on the spot a little bit on this one. But Texas has not expanded Medicaid yet, right? And I don't believe there's any states that have a state-based exchange that didn't also do the expansion to adults under the Affordable Care Act. It seems, frankly to me, that a little, well, obvious to me that we need to do both. Okay, so I'll admit my biases in this, but is there a way that this could work in a state that hasn't expanded Medicaid?
I think so, and I would also just offer that Idaho was a state that had a state-based marketplace without Medicaid expansion for several years. I think by ballot measure, they just expanded Medicaid last year, but Idaho was the sole state-based marketplace that operated without Medicaid expansion. And one of the things that comes with that is obviously folks from 100% to 138% of the federal poverty line are in marketplace coverage and eligible for marketplace coverage rather than Medicaid. So it's certainly doable in my mind. And I would just offer from a user fee revenue generation perspective, and therefore a potential contribution to reinsurance perspective, without expansion, you're going to raise more money because there's a lot of people, there's a lot of potential enrollees in that income bracket between 100 and 138% of FPL who are enrolled in Texas in marketplace coverage because there is no expansion. One of the benefits we've seen of having a state-based marketplace that you wouldn't have without expansion is the coordination between the marketplace and the state agency administering the Medicaid program. We've worked really closely with them this year to make sure that the continuity of coverage, the churning from one program to another based on income fluctuation is done effectively, is done efficiently, that people get to the right program and get enrolled regardless of their program eligibility. That's not necessarily something you can do or you'd see as much without Medicaid expansion, but to the overarching question, you can, in my mind, you can certainly have a state-based marketplace without Medicaid expansion.
Yeah, I agree with that. I think the point made in the question that you would see, say, a higher call volume relative to enrollment because of the gap population is true. But I also think, to Zach's point, that the additional user fee generated from whoever does enroll from the 100 to 138 population would more than make up for any additional costs associated with the customer service elements. There isn't much additional cost for additional people going through the application and then ultimately not enrolling. There's a lot more economies of scale on the technology platform. It would really be kind of any anticipated additional call volume relative to a non-expansion state. And again, Zach can catch me here, but I think those two costs would actually come out as a benefit to Texas from a purely user fee perspective.
I agree.
Help me remember, how many people are in the marketplace in Pennsylvania?
About 300,000.
About 300,000, right? So we're in Texas, we have a little over 1 million people. So we're talking about sort of 3 times the size. Now, a lot of those are in that 100 to 138% category where there's significant subsidies and cost reductions and all that.
Well, for our model, and I think it would be helpful actually if Zach talked a little bit about how economies of scale do and don't play into exchanges, because and how that can advantage a larger state. But the other thing I'll say is, I don't know if you have modeled reinsurance at all here in Texas. Many states have. And the more people you have that receive significant subsidy, the better your federal match rate is, aka the more federal dollars you get per state dollar invested through your 1332 waiver. And so I think for both of those reasons, you might find some pretty good math for Texas going through that process.
And in fact, the Texas Department of Insurance has a procurement out right now to work with actuarial firms to do some of those calculations for us. So
Zach, do you want to talk about economies of scale a little bit and what you might expect for a state like Texas?
Yeah. I mean, just because there's three times as many members in the market doesn't mean to operate the marketplace, it's going to cost 3 times that. It just doesn't work that way. The technical infrastructure is what it is, and while it's going to cost you a little more in a larger state, it's not going to be on a multiplier like 2 or 3 times. And I would say the piece of your operating budget that goes up with membership size is probably your cost for your call center, because at the end of the day, that's just, you have to have enough bodies in seats answering phones to accommodate call volume and member demand. But again, that's not going to be a multiplier of 3. So I would say with 1 million members, there's definitely enough revenue there to both pay for a state-based marketplace and a healthy reinsurance program.
well, and there's also probably another 1 million people in Texas that are eligible for subsidies right now that are uninsured and not signed up.
Yeah.
Because of our lack of embracing the ACA at a state level. At the very beginning, Jessica, you talked about one of the goals being to, not just to reduce costs, but to also to expand coverage and stuff. Can you talk a little bit more about kind of, your overall goals and, sort of the positives of this? Because I keep thinking about this too, in terms of a state like Texas with, over 5 million uninsured people, and the opportunity for the state, not just to have more control, but to have more opportunity, to have more broker engagement, more navigators, more advertising to try to get to reduce the uninsured.
Yeah, it's a great, I mean, there are so many benefits of what we are doing. I almost don't even think I can tackle all of them. I mean, so lower premiums is like easy checkbox. Everyone likes that. Easy to explain to a legislator, like not a problem. But the advantages that come with being your own exchange are really innumerable. And it's not just more of the things that Ken listed, it's better of those things and tailored to your own state. And so first of all, we're branded as Penny. Pennsylvania Insurance Exchange is what that name is derived from. It's a Pennsylvania specific. The marketing has pictures of Pittsburgh and Philadelphia in our advertising, right? It is meant to appeal to Pennsylvania. We are working with Pennsylvania's insurers. We are talking to Pennsylvania's brokers, our navigators, our Pennsylvania's community health centers who are on the ground in our communities every day. And those people are not just who we're talking to, they're also the governance board, which Zach talked about. And so, I think one thing that has really been demonstrated even in the first 2 weeks of Penny opening its doors for OEP is how valuable that working relationship is. Zach can talk more about this, but for example, he and his team have a call every week with each of the 7 insurers in our market, one-on-one calls. They are able to share issues, and Zach's team by and large has been able to address those issues, including technology patches within 24 to 48 hours of finding out about them. You tell me if you have that with healthcare.gov. I'll give anyone $100 who can tell me that happened with healthcare.gov, right? It's a different relationship that is so hugely to the benefit of everyone operating in the ecosystem of that market. And I don't think we've even really scratched the surface of the benefits that we will get from this being Pennsylvania, from being able to pick up the phone and call the Medicaid program and say, we think something's going on, and hash through it together on one whiteboard, right? It's just a different way of operating.
So have the hospitals and doctors and providers generally been supportive of this as well? You mentioned it really briefly, but I was just wondering if they...
Yeah, hugely supportive. And Zach, so one thing we haven't talked about is that we have a governance board and a separate advisory board. And I think it would be helpful if Zach talks a little bit about the distinction, the existence of the advisory board, and what it kind of allows us to do and bring in some of those other stakeholder groups.
Yeah, absolutely. So the advisory council is also required by our law, and it's made up of other industries, primarily other industries not on the governing board. So the Hospital Association is on the advisory council, the Medical Society is on the advisory council, the Association of Health Underwriters is on the council. Other community advocate navigator members are on the council, and then there's another. I think there's 2 other legislative appointments. So that body also meets on a periodic basis. It has a charge of providing expert opinion to both the exchange staff as well as the board of directors about big decisions and strategies and policy initiatives. And it's been very effective in engaging other industry participation in the process, particularly those that are not on the actual governing board. And then Ken, if I just may, one other thing on the previous question that I want to add is a benefit of being a state-based marketplace is our ability to make policies specific to the needs of our state. And an easy example of that is that we decided that the open enrollment period of 45 days was not long enough, and we expanded open enrollment this year an additional month. So it runs from November 1 through January 15th. We did that. The board of directors made that decision. They did that because they felt that there was a need, particularly in a transition year, for more time for people to come in and get covered. We can make other policies around special enrollment periods, around the litany of things that you just can't do when the federal government is in charge of making those decisions.
Yeah, so any sense yet of, are you going to expand enrollment this year because of moving to a state exchange, or you think it's going to be about the same as last year? And do you have longer term goals? You guys don't have as many uninsured as we have here in Texas, but for me, I mean, this is a huge opportunity to reduce the number of uninsured people. And so,
yeah, it's a huge opportunity. The long-term goal is to play a real role in chipping away at that uninsured number over time. I would say in our first year, we have not, we've been hesitant to put out enrollment projections, particularly with the disruption to the health insurance landscape that has been COVID-19. It's just been a little bit hard to understand all of the moving parts specific to the economic impact, what's going on with employer-sponsored insurance, what's going on with COBRA. Medicaid is not, in Pennsylvania, the Medicaid rolls are not shrinking, they're growing, and nobody is being terminated from Medicaid because of federal policies around COVID-19. So it's been, because of that and because of our focus in the first year has been about transition and making sure that everyone comes over and gets renewed. We've been somewhat silent on projections. We're looking to maintain in this first year and then really grow in future years.
I'll just add to that. Sorry. So first of all, huge goal to enroll more people. I will say, just to compare, so I don't know Texas's uninsured rate. Pennsylvania's, as of the latest data, was 5.7%, but so that's very low relative to the national average. But we do believe about a third of those people are probably eligible for the marketplace, subsidies on the marketplace or Medicaid. So that's a really, really critical point. I also, just on COVID, and I think it's very easy that the assumption is COVID, people lost ESI, marketplaces will grow hugely. And I just am kind of encourage folks to put the brakes on that assumption for 2 reasons. One is, I think the fact that Medicaid is not disenrolling and sending people up to the marketplace if their income goes up is a huge factor. The other is that I don't know what you're seeing, but we've been looking at data in Pennsylvania, and ESI is not dropping as much as any of the early projections or predictions. It's been much disruption. It's not, I think, at the level that many people assumed, and we saw sort of some national projections from the think tank world in the spring. And there are a lot of people who are on Medicaid and staying there, and we don't know if or when they will come up to the marketplace.
And one sort of nerdy question about the reinsurance. I'm sorry, I should have asked this earlier. what are the parameters of the reinsurance, just in terms of the, is it claims between 50 and 200,000, or what's the?
Putting Jessica on the spot. I like it. You're on mute, Commissioner.
I had a slide for that, so I pulled it up. So good. Thank you for prompting that. The reinsurance parameters are up here for if we have any actuaries on the phone that want to see.
You need to share your screen. You're not sharing your screen.
Oh, I never stopped sharing my screen. Let me see. Can you see it?
Yes. Okay.
There we go. Okay. So here are reinsurance parameters on the screen for you. So we are paying 60% coinsurance on any claims between $60,000 and $100,000. Directly answer your question.
Okay. Yeah, and that different states have different caps and different things, and so you guys obviously had actuaries who felt that was kind of the sweet spot.
Yeah, and I guess I'll say, if you want to get really nerdy, which some of you probably do and some of you are saying please don't, but there are many states have broader corridors at a higher claims level. And that actually, as we looked at our market, would have resulted in a tightening of premiums because some carriers disproportionately have those higher claims. Risk adjustment plays a role there, which actually could have potentially impacted the second lowest cost silver and kind of the tax credit value. And we didn't want to do that. We didn't want to have anything that we were doing to help the over 400 do anything to harm the under 400. And so having the lower cap was kind of a sweet spot for us of being able to do both.
Right. Well, we have time for one more question, and as the moderator, I get to ask it. Sorry for those of you in the Q&A. But one of the things that we've also been watching here in Texas is what Georgia has been doing with having multiple private exchanges rather than a state-based exchange. Did you guys consider that at all? And what's your reaction to what they're attempting to do in Georgia?
So we didn't consider it at all. To be quite frank, I'm not an expert in the Georgia waiver, so I'm not sure I can even speak in a totally intelligent and informed way about what they're doing or how what they're doing compares to what we're doing. I think they're, first of all, there's a lot of talk in the exchange world that you can kind of let the vendors run with it. They can do everything. The state can kind of just do a contract, check the box, and be done. And that has not been our experience. Not that the vendors haven't come a really long way. Not that they don't have a lot of the things really buttoned up and ready to go. But the state's vision, the state holding them accountable to metrics. We have some very high bars on metrics of customer service, for example, that Zach spends a lot of time talking to them about and making sure that we're hitting, making sure all of the different pieces are integrated and that the marketing is there and working is really, I think, a thing that Zach's team takes on. And so, it'll be interesting to see what happens in Georgia, but I would say I'm not sure, even if you want the private market to be there to take this on, I'm just not sure they're actually there yet from what I've seen.
Well, thank you guys very much. We're at our time limit, and as the two of you know, I could continue to talk about this all day and at an incredible geeky level, but we so appreciate what you guys are doing, and both to help us here today, but also for the folks in the Commonwealth of Pennsylvania. I know that you guys are doing great work out there, and I wish you guys the best of luck as you continue your path, and we'll check in with you and see how it's going over the next couple of years. Appreciate it very much, and thank you for being here today. For those of you on the rest of the conference, we're going to take about a 5-minute break, and we will be back at 9:30 with another panel discussion on the role of marketplaces in re-envisioning commercial health insurance with Kathy Rosenberg from the Robert Wood Johnson Foundation. So come on back in 4 minutes now. We'll start up in just a few minutes. Thanks, everybody.
Thank you.
Thank you.